Jana, and we hope your voice continues to be increasingly released. So I want to welcome everybody and thank you for joining. This is tonight's first, AHP's first maternal child health grand rounds. We've done pediatric grand rounds before, so we're moving into in the right direction of being more inclusive and broader minded as we're thinking about the first 1,000 days of a child's life, and we're thinking about the full care for pregnant people, including the 4th trimester. This session is going to bring you up to date on some of the latest population health innovations for patient and family-centered perinatal and pediatric care, along with a critical view of the current state for women, pregnant persons, children, and families, and a forecast for our opportunities to shape the future for their healthcare. So this evening, I'm going to keep our speaker introductions short because I want to maximize our time to learn from them and your chance to interact with these experts. So our first team of presenters are really absolutely a powerhouse for high quality and innovative gender wellness OBGYN care. I've had the privilege of working with them, as have many of us within AHP, over the last 4 years as they have built a maternity patient-centered medical home with a highly skilled interprofessional care management team. I'll introduce the 4 presenters quickly, and then we'll turn it over to Dr. Pressman to make first comments. So Dr. Eva Pressman is the Henry A. Thiede Professor and Chair of the Department of Obstetrics and Gynecology at the University of Rochester. Jenna DeSimone is an RN Care Manager for the Gender Wellness OBGYN practice. Dr. Ellen Polishuk is a professor of psychiatry and obstetrics and gynecology, the academic chief of UR Medicine's Psychiatry Division of Collaborative Care and Wellness, and the director of the Program for Mental Health and Gender Wellness in OBGYN. And Dr. Ellen Tortolo is an associate professor of pediatrics and gynecology and the medical director for the Gender Wellness OBGYN practice. Their presentation is entitled A Population Health Focus for Perinatal Care, Gender Wellness OBGYN's Interprofessional Perinatal Care Management Model. Dr. Pressman will lead off with some introductory remarks. Thank you for joining us, Eva. And then we will turn to Jenna DeSimone. Jenna, feel free to share your screen and PowerPoint as Eva's speaking. Thank you.
Well, thank you so much, LJ, and thank you all for inviting us to speak. As LJ mentioned, this is a program that has really evolved over several years. I guess it has been 4 years. It feels much shorter since 2 years was in this pandemic time where it doesn't really count for time. But we're really excited to share the program itself and some of the preliminary results, which are really quite remarkable. Our goal was to introduce care management, both medical care management and behavioral health care management, into a clinical setting where many individuals are at great risk for poor obstetrical outcomes. And that is related to both their obstetrical history as well as the psychosocial stressors that they are facing in their lives. And so I did very little of this work other than to continue to be a champion throughout. So I'm really happy to turn it over to the people who did the work, and I'll start with Jenna. So thank you, Jenna.
Thank you so much. Thanks for having us today. I'm Jenna, one of the RN Care Managers at Gender Wellness OBGYN. And today myself, along with Dr. Ellen Tortolo and Dr. Ellen Polishuk, are going to share with you the programs of RN Care Management and Behavioral Health Care Management and discuss how we've implemented them over the last 3 years. I'll start off with the goals of our program. We'll talk through the structure, the outcomes, and sustainability of both the RN Care Management Program and Behavioral Health Care Management Program. Throughout the presentation, you'll also hear behavioral health, the behavioral health program referred to as collaborative care. A little background on our practice. Gender Wellness OBGYN, or GOG, is formerly the Women's Health Practice, and we are Strong's ambulatory OBGYN office, providing OBGYN care for the BIPOC and low-income individuals. And these individuals have multiple barriers to care. These barriers put our pregnant population at higher than average risk for poor birth outcomes. We send about 700 baby deliveries to Strong Hospital per year. In addition to pregnancy care, GOG also provides full spectrum GYN care, menopause care, and care for transgender patients. The goals of our care management program as a whole were guided by the quadruple aim. We set out to target patients who are typically at risk for poor birth outcomes, including patients with depression, hypertensive disorders in pregnancy, adolescent pregnant patients, and patients who smoke in pregnancy. Initially, we received grant funding that allowed our practice to build a care management infrastructure. With our initial funding, we successfully implemented 3 evidence-based approaches to improve health disparities. First, perinatal nurse care management for pregnant patients with modifiable risk factors. Second, collaborative care management for pregnant patients with depression or anxiety. And third was the ROSE program that was made available to all pregnant patients to reduce the occurrence of postpartum depression. Our program also began with a project manager and a consultant from the Center for Community Health and Prevention that got us up and running with our tobacco cessation interventions. When we set out to implement care management in our specialty field of obstetric care, we were working in relatively new territory. Care management has been an essential part of primary care for a number of years, but there were few to no models of a practice-embedded care management program that has had proven outcomes. So we set out to build our own program. The next slides focus in on the RN care management program goals, interventions, the interventions that worked towards our goals. Again, in fidelity to the quadruple aim, the goals of the RN care management program focused on reducing the cost of care, reducing NICU admissions, reducing unnecessary hospitalizations, and we also aim to improve outcomes through standardization of care across the practice, improving health literacy, and removing barriers to care. Last but certainly not least, our goal was to support the providers through team-based care and strong interdisciplinary teamwork. All of this in effort, of course, to reduce burnout and extend the reach of the provider. The RN care management model began with 2 embedded nurses that focused in on moderate risk OB patients. Each care manager had the capacity to carry a panel of 45 to 60 patients with 1 or more of the risk factors that we identified. The initial interventions were designed for adolescent pregnant patients, patients who were smoking in pregnancy, and those with a history of preterm labor in a prior pregnancy. But in 2020, our focus shifted away from preterm labor patients as the medical recommendations for their management changed. We focused then on patients with a hypertensive disorder in pregnancy. So this is your chronic hypertensives, gestational hypertensives, and those with a history of preeclampsia and a prior pregnancy. By managing these at-risk groups, our goal was to mitigate any modifiable risk factors and move them toward better outcomes, more reflective of the low and normal risk population. So on to the how. How can we impact these patient groups? Our interventions were planned based on the needs of the group. For example, the interventions for the adolescent patient focused on education, care navigation, and reproductive life planning, while the hypertensive patients were supported also by care navigation, but also time spent on disease-specific education, obtaining blood pressure cuffs, assessing fit, calibration, and teaching proper home use. The interventions for current or former smokers focus in on motivational interviewing and patient-driven support to work toward the individual's identified goals of quitting smoking, reducing, or remaining smoke-free. Some achievements of the program, the list, it's wonderful, the list is long. We standardized care, we formed interdisciplinary teams, we've implemented transitions of care contact for patients after evaluation in OB triage, after postpartum discharge, and in addition to all those, adding on to that, for the hypertensive patients, we also operationalized the most up-to-date practice guidelines recommended by ACOG. We've worked to standardize care across all practice providers, and we've implemented home blood pressure cuff use for all patients with a qualifying diagnosis. Highlights specific to the GOG tobacco cessation program included the training of our nurse care managers through Roswell Park Cancer Center as tobacco treatment specialists, our successful partnership and ongoing relationship with the Center for Community Health and Prevention surrounding tobacco treatment. And we've extended providers' reach as the RN care managers were able to help providers become more of an expert with prescribing nicotine replacement therapy and in counseling patients. We also implemented billing for RN cessation counseling time, which has helped when we get to sustainability as well. Some more general program achievements. We've updated a referral process. We have updated the new prenatal intake process. We've created care maps that guide the outreach and interventions through pregnancy based on risk factors. We've implemented closer postpartum follow-up as suggested by ACOG. We've overcome barriers of time and space through telephonic follow-up. We've established a data bank for tracking our impact and our outcomes. And in the height of COVID, we pivoted as care managers to better support the practice and took on additional roles. but the data. So what did our work accomplish? And as I show you some of the data and outcomes for the project, I'll mention that the baseline data specifically for these moderate risk groups were lacking. We considered the low risk population as our control group, and our aim was to bring our moderate risk patients, their outcomes as close to the low risk patient group as possible. In some areas we came close, and others we surpassed the outcomes of the low risk population. So on this slide, overall care managed patients attended more prenatal appointments than non-care managed. And I think we can attribute that to better patient engagement, working one-to-one with a care manager. Our patients have a one-to-one connection with the office. This slide looks at birth weight for care managed versus non-care managed patients. And when we look at the outcomes on birth weight, we have to keep in mind that the care managed groups at higher risk for preterm births and low birth weights. So to close the gap is a success for care management. In 2020, the non-care managed control group delivered more normal birth weight babies, but by 2021, we turned that around and care managed patients exceeded the control group in normal birth weight outcomes. This slide looks at NICU and NICU step-down admissions. The infants of the care managed mothers had significantly lower rates of admission to NICU or NICU step-down. And in 2020 and 2021, the rate of NICU admission among the care managed patients was significantly lower than non-care managed. We know that NICU admissions cost thousands of dollars per day. So the reduction of NICU admissions is critical to reducing the cost of care. And with this next slide, I'm going to hand it over to Dr. Turtellow to talk about the outcomes of the GOG cessation program. And Dr. Turtellow, let me know if you want me to give the background on this slide before you speak.
Well, this slide represents the people that accepted care management for smoking cessation. So basically that added up to 67 patients. And with care management, you can see the amount of time that the care manager spent with the patients. And we grouped it into 3 categories: those that quit with care management, which was 39% of the patients; those that reduced smoking with care management, which was 39% of the patients; and then those that didn't quit or reduce, and that was 22%. And as you can see, the more time spent, although there's not a significant difference really between 89 and 92 minutes, but there is between 69 and 92 minutes. So the more time spent is significant. And this is time that providers don't have. So this is extending the provider's reach. Typically Jenna and Linda, and now the new care manager, Kim and Lisa, can do this either when the patient's in the office as a team-based visit. They either go in before or after the provider, or they can do it by video or phone. What's not on this slide, which I thought about earlier this evening, was that there were also 32 patients that were that quit on their own when they found out they were pregnant, and they were entered into relapse prevention with the care managers. And all 32 of those patients remained smoke-free throughout the pregnancy and through the delivery. And only 4 of them relapsed postpartum. So that was a significant win for us.
Absolutely. Thank you. So as we think toward the future of care management, we have to think about the financial sustainability of the program. The OBGYN department fortunately recognized the value of care management in the pregnancy setting and the successes of the program in our work towards the quadruple aim, including the huge potential for saving healthcare dollars and improving birth outcomes. When grant funding ended, the OBGYN department took over funding for our 2 existing care management roles, and we're very proud to report that our program is expanding to include the addition of a 3rd care manager and some new initiatives to further improve the care we provide. In addition to departmental funding, care managers billing for cessation support contact time has also helped offset the cost. We're very proud of the transferable process of RN care management, and we have seen some expansion already in the region with Highland Family Medicine and Highland Women's Health piloting some similar models. And at this point, I'll turn it over to Dr. Ellen Polishuk.
Thanks very much, Jenna. I'm Ellen Polishuk. I'm really pleased to get to be working with this amazing group and to be talking to you about the work today. I do want to say I'm representing the work really done by other people who aren't here tonight. So our Rose clinicians, The first one was Cassandra Uthman and currently is Kizzy Lee. And our behavioral health care management manager is Eileen Steichen, who made many of these slides and is home taking care of her newborn baby. So I'm grateful to get a chance to talk to you on their behalf. So ROSE is stands for Reach Out, Stay Strong Essentials. And one of the things I think is most exciting about it is that it's an evidence-based prevention program, which has been found to reduce risk of postpartum depression by 50% in at-risk women. And it has been recommended by the U.S. Preventive Services Task Force and can be delivered by a layperson or by a clinician, depending. Next slide, please. So just to give you a little bit of information about what ROSE is, it's a 4-session prenatal intervention plus 1 postpartum session that really provides education about what is postpartum depression, what are typical role changes, how can one learn to engage in relaxation exercises and positive care activities, how can you learn to ask for support appropriately and say no, what does it mean to be in an abusive relationship, and really overall coping skills. Next slide, please. And so we have delivered ROSE with 67 patients, and we found, so the PHQ-9, as all of you know, 10 and above suggests clinically significant depressive symptoms. And we started with a score of 8, and then the postpartum mean for those that we have data on was 6.8. So rather than going up like it does for most postpartum women, we actually saw a decrease, suggesting that we were having good outcomes. Next slide, please. Behavioral health care management. So this is the one that Eileen administers in our context. Next slide, please. So this is another evidence-based intervention that is really the collaborative care approach that I think some of you are already familiar with out of the University of Washington, and for depression and anxiety integrated in primary care. But it has not been conducted much in OBGYN settings. So bringing it to an OBGYN context, it was a novel opportunity. And so Eileen adapted it to work with our perinatal population by using a registry. We formalized our screening, which had been happening, but not as consistently as we would like. And we now screen 3 times during the perinatal period, twice prenatally and 1 postpartum. And Eileen reviews all positive scores and invites patients for a conversation, and then works with the team and with our psychiatrist, now Dr. Eiler, it was Dr. Ainsworth, to provide consultation as needed to our patients and our providers. Next slide, please. And so the program goals are to decrease anxiety and depression in our pregnant population, to make care more accessible, to have shorter wait times to access care and provide team-based care. We already had integrated psychiatric consultation and psychotherapy, but this really expanded our continuum of care for that gap where patients might have been having difficulty engaging in care, having poor follow-up, having crisis needs, needing a warm handoff, and it really helped us with that. Next slide, please. So the outcomes that we have here, we had 307 pregnant people who received collaborative care management, and 73% of those showed clinically significant improvement in their depressive symptoms, which we defined as having symptom severity scores lower than 10 or symptom severity reduced by 50%. And so you can see also that the engagement significantly increased in year 2 of the program over year 1. So then our next steps have been to think about sustainability and how can we continue doing that. So as you saw in Jenna's earlier slide, the funding for our ROSE interventionist went away following our initial 2 years. So what we actually did was provide training to a tech in our practice, Kizzy Lee, who has done a great job of in her usual workflow, educating patients as they're getting their vitals taken about the program and then making the program available. We have a drop-in Zoom session and individual in-person sessions that she's offering. And so that has been exciting to see that continue. And then in terms of the behavioral health care management, there were Herculean efforts made by many to figure out how to make charge capture happen within EPIC. And so that can now actually be paid for to cover the costs, which also really helps with dissemination throughout our system. We just received approval to have a behavioral health care manager at Highland Women's Health and are in the process of setting that up. And we're super excited about that. And so this is really helping us to pave the way, and it is also allowing us to expand collaborative care in other primary care contexts in our setting. So that's it for me. Thank you.
Thank you. I believe this is sort of a duplicate slide. I'm going to step over to this slide here. In talking about the next steps for the care management program as a whole, we've turned our aim from quadruple to quintuple, and now focusing on health equity for our underserved population. We have some additional projects going on, focusing on getting blood pressure cuffs and for patients who are unable to purchase or not covered by insurance, to better serve them with more consistent care and providing them the opportunity for self-monitoring at home as well. And some acknowledgements to all of our allies and supporters. Thank you so much. There's many people that got this project off the ground. So thank you.
Thank you so much for that presentation. I wanted to give everyone 5 minutes or so, 4 or 5 minutes. If you have questions for the team, please feel free to unmute, or if you're more comfortable dropping your question in the chat, feel free to. I'm gonna monitor the chat and I'll say some things as we go. I love Doug Bennett's comment here right now. So I don't know if folks can see it, but I will read it out loud. I think the ROSE program is great, and I'm impressed with the success. Would love to get the pediatricians involved as we continue to see the mothers after the delivery. Ellen, I wonder if you could comment on what role you envision for the pediatrician, and we can talk a little bit about established referral network there too. Thanks.
Yeah, I'll let you speak to that part, but this is something that LJ and I have been talking a lot about in terms of how do we improve the continuum of care across families and really support families through this transition of parenthood. And even though the data aren't there to administer ROSE postpartum, we're really, I think there's a lot of reasons to think that the content and the intervention is relevant, even if you didn't initiate it into the postpartum period. And so I would be really excited to think about how can we either get it started in the prenatal period and finish for people who didn't, or extend the support and continue to provide that support in the postnatal period, or to even try out administering ROSE in the postpartum period and see how that goes, because all the concepts continue to be really relevant.
Thank you so much for that, Ellen. I agree. And you know, Doug, one of the things that we're piloting right now, but we're not at the point ready to do full expansion, but we've been looking as a community at a universal telehome newborn home visitation model to complement the kind of the incredible interprofessional care management model that happens within the GOG practice, for example, but also what can happen right after the birth of a baby in supporting families kind of coming out of the pediatric medical home, but time back. So we've got some initial work that's happening right now in the safety net practices, the large safety net practices, Rochester Regional, California Children's Hospital's pediatric practice in Jordan. We had an initial start with a pilot with AHP practices. We had to pause that because the model we were looking at really is an RN, that was exclusively an RN model. And as we all are well aware, the RN shortage for your practices has made lifting this kind of work difficult out of the practice. But we're modeling some things now with an interprofessional team and looking at ways to make it portable. So I would stay tuned on that, because that will allow us some increased referral resources and connection, and hopefully be bringing some of the work of the ROSE team, the ROSE work, and others. The last thing I would just say, and I don't know if George Nazra wants to comment on this, but Project Teach has taken on, a real focus on maternal depression and anxiety. And George, I see your face on here. You're not unmuted, but I wonder, do you want to just speak for a moment about Project Teach's role in that space?
Thank you. And Ellen is part of that effort as well. So Project Teach this year has expanded from being purely a child health initiative and support for pediatricians to now also supporting OBGYN providers. Dr. Jeff Eiler, who you heard the name of, is the lead psychiatrist on that team. The idea is to provide consultation support to OBGYN providers, but also to other psychiatrists as well who are managing peripartum individuals, and provide recommendations for medication management, for therapy, as well as for a referral and connecting with care. So we're excited about this. The next step in this program is connecting Project Teach as a maternal mental health initiative with the pediatric in a real way, and that's really, in my mind, the frontier of that, maternal child health initiative. If I can take just a minute, LJ, also to say that, in my opinion, the collaborative care model can potentially be adapted to that maternal child dyad as well. Now, LJ and Jeff and I met with a team from Albany to start a conversation about that. There are many obstacles, but I'm kind of cautiously optimistic that we will get there, and adapt this model to supporting parents in their effort to manage their own health, and how the impact of that is seen on the child as well.
Thank you, George. And I think just the last thing I would say, since so many of the folks in our Zoom room are pediatricians or pediatric care providers, we will really be looking to you as we begin to think about these next steps, and how we build this out within the primary care practices, for you to take a look at some of the modeling we've done, to reflect on it, to inform that process. So I'm excited to reach out with you. 2023 will be a great year for us in that space. I think really trying to move forward in this area. So thank you for your questions. Thank you to the GOG team. We really appreciate the incredible work you've done. I'm going to move us on to our next presentation. Our next speaker is Catherine Whiteman, but she does go by Katie. Katie is an international board certified lactation consultant, or IBCLC, who championed the start of lactation care management within AHP and UR Medicine's care management organization. She also provides lactation consultation and support as the founder and owner of Breast for All LLC in Dansville, New York. Katie's topic and title is Advancing Health Equity for the Rural Population. Thank you, Katie.
Thank you, LJ. Can everyone hear me okay? Okay, excellent. And Jana, you're advancing my slides for me? Okay, perfect. Thank you. So while we're still on the title slide, I just want to connect us to our larger context a little bit. So we're here talking about maternal child health today, and the larger context of the role of care management for lactation is our understanding that lactation care is critical to population health, because that parent and infant dyad, when we're looking at the total health of that parent infant dyad, on the obstetric side, lactation care is an important piece of healthy pregnancy recovery. On the pediatric side, human milk is playing a really important role in the development of healthy immune systems. And then for that whole dyad, breastfeeding and chest feeding really support normal endocrine function in both halves of the parent-infant dyad in the short term and the long term. And it's also true that highly skilled lactation professionals are typically serving small portions of our population. Okay, so isolated, impoverished, and marginalized populations have the least access to skilled lactation care. And the consequences of that being that rural populations tend to have the lowest rates of human milk feeding and subsequently higher rates of the diseases that we associate with not breastfeeding or chest feeding. These issues are not limited to rural populations by any means, but we started here with our programming because this was an area of great need. So the issues and solutions we're talking about today are going to feel familiar because they are applicable to the patients that you're serving also. Lactation care is limited for all of us. It's severely limited for some of us, which brings me to a thing I like to acknowledge before I talk about lactation care. And that is that the populations that we serve are the populations that we live in. So our own families represent data points on those regional breastfeeding and chest feeding rates when we're looking at our CDC report card and all of that. And so this is likely to be a personal and probably difficult topic for probably the majority of us here. But it can be a healing topic also. You know, as we are looking at programming in this field, we're talking about inventing the supports that we once needed for ourselves and couldn't access. So this is challenging professional work, it's challenging emotional work, but it can be a healing process as well. And can we have the next slide, please? Okay, so on this slide, I want to show you the impact of our intervention on our target population and then compare our breastfeeding and chest feeding rates to some benchmark data. To date, we have had 589 dyads enrolled in the program. So that is 1,883 people and 1,183 people. That's more than double because we did have 5 sets of twins. Okay, so that's a lot of people that have been served by this program. The top line of the table that you see here of the larger table is showing our breastfeeding and chest feeding rates at discharge at Noyes Hospital, and that Noyes Hospital is kind of our home base here. We're seeing families before, during, and after their hospital stay at Noyes. So we're looking at before the intervention, in the first full year of the intervention, and then in the third full year of the intervention. And the happy little face there is my daughter on her 3rd birthday. She's 10 now, but this picture I just felt really embodied my enthusiasm for our 3rd year data because I was feeling pretty pleased when we crunched these numbers. So below that first line, you see 1 month, 3 months, and 6 months, and that's our rates of human milk feeding at those points. Where you see it say EBF, that stands for exclusive breast milk feeding, and that may include some pumped milk when the parent is returning to paid employment. The majority of this population is returning to paid employment between 6 and 12 weeks postpartum. Where you see the word any, that means any breastfeeding. So some of that child's diet does include formula. We did see a boost in our data during the quarters where there was the formula shortage, which really, I think, illustrates the importance of this type of program. In urban and suburban areas, the stores that carry formula are close together, within a few miles of each other. Out here, if you are driving from store to store in search of formula for your child, especially if you need a specific one, you might be traveling 25 or 30 miles. One family that I worked with in this program, whose child was prescribed a diet of breast milk and EleCare, they had to drive 56 miles at $4.50 a gallon to get 2 cans of EleCare. They had to call all over the place to find some place that had it and could get it. It was being rationed. They were only allowed to take 2 cans with them. And then once those were gone, they had to do that whole process again. So obviously supporting milk supply for that dyad was really important. So this programming is important all the time. It's really, really important in a crisis. The smaller table that you see there is comparing our data to our most recent CDC report card. So our exclusive breastfeeding rates at 3 months are roughly 30% higher, and at 6 months are roughly 26% higher than the general population in New York State. And I do like to point out that the CDC report card is all comers, right? This is the general population. Our population does skew toward higher levels of need. 90% of our enrollees have at least one risk factor for premature weaning. 66% of our enrollees have 2 or more risk factors for premature weaning. And since beginning this program, Noyes Hospital also received a shout out on the US News Best Hospitals High Performers list in 2021 for our breastfeeding rate at discharge of over 70%, while the average in the Northeast is 45.8%. So it was really validating to see a third-party confirmation of our findings in this program. Can we have the next slide, please? To get these results, we had to take a really close look at what was stopping families from achieving their breastfeeding goals. And those barriers, those systemic barriers that we found were really what we turned into the goals for our program. So in general, we know that 80% of formula feeding families wanted to or attempted to breastfeed or chest feed, but weren't able to meet their goals. Looking at our local population, we could see as we were getting started that some folks qualified for income-based lactation support programs. Some folks could afford to travel to and pay for lactation care. Some folks were able to get help through county health programs that were not income-based. But those programs, you know, this program serves 4 counties. Only one of those counties had a non-income based lactation support program. So really the majority of our population did not have access to lactation care. And I want to stress that all of those professionals that I just mentioned in the county health programs and our lactation support persons, all of those people are working hard and doing great work, but are having trouble getting access to the patients that need them, and the patients are having trouble getting access to the providers who can help them. So when we were working on this build, we knew we needed to address that. We knew that we needed to create a structure for linkages and communication between the spaces and the providers where breastfeeding and chest feeding dyads are receiving care. And it was also really obvious as we were talking to these providers and envisioning solutions that we've got this lovely continuum of care from pregnancy through weaning for parents and babies and young children. And those folks who are doing that work are really getting great outcomes for pregnancy, birth, and early childhood. And they're busy doing that work. And in rural medicine, we're always facing a provider shortage too. So as we were building this program, we realized right away that whatever solutions we come up with could not be solutions that were adding burdens to an already overburdened system. So we needed to make sure that we were adding support not only for patients, but for providers. And we really needed kind of a lactation captain, right? A person who could hold space for lactation outcomes and goals while all of those other things are going on. So we created this lactation care management role so that the other folks on the healthcare team can continue to champion the outcomes of their specialty and their scope of practice. So that's really what an IBCLC is trained to do. And in that role of care manager, we have our IBCLC bringing lactation and infant feeding expertise, supporting families with their education and their goal setting around their feeding method, and then communicating with primary care providers as well as specialists about optimal feeding outcomes for each dyad. And with that understanding that optimal feeding outcomes are going to be really individualized for each dyad. So we needed a role that could incorporate that whole scope, right? So an infant with an oral facial anomaly, a parent with a history of breast surgery, or a parent who's in addiction recovery, those are going to require some really individualized care plans to make sure that we're getting optimal feeding for that dyad. So can we have the next slide, please? All right, so on this slide, these two belong to me also. I want to talk a little bit about those foundational pieces that really help to drive the success here. There's a lot that goes on behind the scenes and that we had to do before we got to the part where we were building that real-time experience of patients moving through this program. So we had to start with a lot of relationship building with all of the professionals who would be touched by the program and make sure that we were hearing their needs and that we were building a shared vision with them. We needed to create structured screening tools so that we could assess lactation health during pregnancy, breastfeeding and chest feeding during the establishment of milk supply, and during that maintenance phase of milk supply. So we would have information to use as we were trying to guide patients to the appropriate levels of care for their situation and for their goals. We also had some infrastructure gaps that we had to address. For example, our local DME providers were not stocking high quality breast pumps, right? So we had our OB providers working really hard trying to connect patients to good breast pumps, and there were just none to be had in this area. So we had to fix that, right? And that seems like small stuff, but it's really big stuff. A bad breast pump can break your breastfeeding experience. And we were seeing so many families start off great and then get to that transition to paid employment, and their breast pump was just not doing the job that we needed it to do. So we had to look at that infrastructure and make sure we had that foundation built. So if we can look at the next slide. This is kind of that real-time experience. So we have 6 patient contacts. That's our minimum. Sometimes babies' needs don't fit a schedule. And so patients do have the option of calling and talking to their lactation care manager if they're having an issue that happens outside of our regularly scheduled visits. Our first visit is happening in the obstetric office during a regularly scheduled obstetric visit. So we're not asking patients for additional transportation costs, right? We're trying to keep the inertia low here. And during that obstetric visit, we're screening for risk factors for lactation issues and coaching patients on managing those. We're also connecting to breastfeeding or chest feeding classes, community health programs that support our breastfeeding and chest feeding dyads, as well as breast pumps. And then what we're looking at those screeners, and if there are any health issues that relate to lactation, we're communicating those needs to relevant members of the healthcare team. In the hospital, we're screening again, and we're coordinating with the hospital staff and the providers who are taking care of the parent and the infant, and making sure that we're creating a safe feeding plan for that family to take home that keeps the baby safe and is in alignment with the family's parenting values. At our pediatric contact, we're going through that screening and coaching and connecting process again. We're checking and making sure that that feeding plan is really working. Was the weight loss within a safe limit? Is the baby gaining weight when they're supposed to gain weight? Is the jaundice level going the direction that it's supposed to go? And we're making sure again that we're making that plan with the family and with the pediatric provider so that we have a safe plan that is in alignment with the family's values. And then we continue to stay in contact with families until the baby is 6 months old. The contact points are at 1 month, 3 months, and 6 months. And that allows us to continue offering support during those transitions to paid employment and complementary foods that can sometimes be challenging to feeding plans. Can we take a look at the next slide? So one of the great things about this program is that it's always using feedback to fine tune the model, right? So this little happy face here is the same girl from the first slide in an earlier phase of birthday cake development. So, so if you want to have great success, you have to start with great ingredients, right? So for lactation care, that really means building continuity by drawing together our existing resources and knowledge base so that we're helping each family unit learn about their own personal needs and their own barriers so that we can help them navigate around that. Once we have screened for issues, we're ready to help families kind of choose their own parenting adventure by facilitating equitable access to the level of care that they need for their goals. Our hope is to bring evidence-based care that improves outcomes while also empowering patients to manage their healthcare interactions and their goals. And we want them to be in the driver's seat with their parenting values, while as the lactation care managers, we're focusing on clearing the way and reducing systemic barriers. So we're hoping that the data that we're gathering here and our learning is going to help to expand this innovative model and lactation care management so that it's part of our network-wide strategy. And that is my last slide.
Thank you so much. I just want to say we're grateful for all of your incredible, thoughtful work. And we're so excited about the results that you're seeing, excited to see how that can expand to other rural areas as well. And I think that, this is a topic that obviously resounds with so many of the folks who are on this call, our pediatric partners, our partners from OBGYN as well. We're fortunate in Rochester. We have a division of breastfeeding medicine. We have this lactation care management model. We have many of our pediatric practices with CLCs on their staff. And I think that you could have done a whole grand rounds, as could the GOG team, as could Jeff Kazarowski, but we asked for sort of small feedings to get everybody thinking together. But I think there's a real space in here that we want to explore again in this upcoming year. How do we connect some of those extensive resources that are practice-based with some of the great lessons that you've learned in this model and with some of the resources we have within UR Medicine as well. So if you have specific questions for Katie, go ahead and drop them in the chat. If you would, I'm going to hold those till the end. If you haven't introduced yourself in the chat and put your practice name, please do that as well. But I'm going to go ahead and move forward and introduce our last speaker of the evening. Most of you know him, Dr. Jeff Kazarowski. Is a professor of pediatrics and vice chair for community and government relations at UR Medicine Department of Pediatrics and Gulf Central Children's Hospital. He is the original founder and now senior advisor to the Children's Agenda, advocating for effective policies and evidence-based solutions for the health, education, and success of children. Jeff will speak to us about the current and future state of maternal health for our maternal child health, for our region. Thanks, Jeff.
Thank you. And thank you, Jana, for helping me. Jana has been patient as I've replaced some slides and is also going to advance slides for me. Welcome, everyone. We'll move on to the next slide. For all of your CME credit purposes, I don't have any financial conflicts to disclose. So we're going to do a few things in the next 15 minutes. We're going to review the state of maternal child health in our region. We're going to talk about successes, and we're actually going to envision the future a little bit and dream. And the last thing we're going to do is to give you a chance to advocate. No phone calls are required, but you do need some typing skills. But the first thing I want to say is thank you, thank you, thank you. To all of you health providers inside and outside of the medical center, in primary care and in OBGYN, you were on the front lines and acted really as our public health system in many ways for the last 2 years. And I know that's exhausting and it's not right. And we're going to talk about that, but thank you for doing it. And to AHP for stepping up to engage as a public health entity. You know, I have this great image of Chad Teeters delivering PPE to various different practices from the back of his car during COVID. For financially supporting practices, both in terms of payments and also in terms of making loans available through some of our regional banks. Loans that didn't have to be repaid if you met certain criteria. And for continuing to do the work that you just saw. I mean, those presentations were unbelievable. Like, they should have their own grand rounds and we should take them on the road. Katie, you guys, and the women's health practice, you guys are unbelievable. I mean, for those of you who are able to, you could clap now, or you can indicate clapping through your, through your screen if you are not. Now let's see. Oh, Holly Brown is really there. Oh, that's good. A lot of people don't seem to be there. Ah, there's a few more. All right, we're working on it. All right. I mean, those are truly outstanding presentations. And can you imagine that this work got lifted during COVID? And in similar fashion, I really want to say thanks to the Department of Pediatrics one department of pediatrics across all hospital systems, and including our community health centers and primary care. And because we continued to do things for kids and tried to innovate and be creative during a time that was really difficult. So thank you. That's the first and most important thing. And just so you don't think, we can go on, Jana. And just so you don't think I totally view the world through rose-colored glasses, the state of maternal health and child health in our region is bad. And it isn't just us. It's bad in New York State, and it's bad in the entire United States. Children and young families are the poorest and most diverse demographic in our population in the United States, in New York State, and in our region. Kids and moms are poor. Our infant mortality rate in the United States places us 53rd in the world, the number of babies dying within the first year of life. And our region is actually worse. If we were our own country, if Finger Lakes region was our own country, we would rank about 61st in the world. And there are horrible disparities by race. Everyone has talked about equity today, and we need to do more for kids who need more. Our infant mortality rate is 3 times greater for Black infants and 2 times greater for Hispanic, Latino infants in our region. This is data from ACT Rochester on the slide. I've said everything that's in the graphs, but they're there for your reference in the future. Next slide, please, Jana. And in maternal health, it's not any better. So the US maternal mortality rate is the worst among all industrialized countries, and it's getting worse. So the work that GOG is doing, and Eva, you have been a tremendous visionary leader, and your team has been fantastic. That work needs to be spread all over. Maternal health overall in our region has also worsened. This data is not, all this data lags behind. So this is data as late as 2018 and 2019. And again, there are horrific disparities by race. Maternal morbidity and mortality is greater for Black mothers, Hispanic, Latino mothers in the US, in our region. And it's not only are there tremendous disparities, the disparities are actually getting worse. And for every woman, they are getting worse. So if you're white, you're Black, you're Hispanic, you're biracial, everyone is doing worse, which is not the company I think we want for our women to be in. Okay, thanks, Jana. So I do want to talk about a couple things in addition to infant mortality and maternal morbidity and mortality. The US ranks last in early childhood health of the 21 richest countries in the world, right? So in pediatrics, we devote all this time and energy to making sure that kids can grow up well. And we do an amazing job in this community. Our community is lauded for primary care all over the country. But early childhood health is not a priority in the United States. And that's seen in terms of what's happened in public health during the pandemic. And it's seen all the time in terms of developmental outcomes and school outcomes for kids and families. New York ranks 27th out of the 50 states for child well-being. That's Annie Casey Kids Count. And New York ranks second to last of all states in the percentage of children receiving developmental screenings prior to school. Now that's old data, it's 2018 data, and our region is doing way better than that. And I would like to be able to update that data for our region, and I just can't figure out a way to yet, but we will. I want to talk for a minute about Medicaid because you all know this because you all, or most of you all have to work with patients on Medicaid all the time, whether they're Medicaid or Medicaid managed care. But Medicaid is the #1 insurer for kids and families now, which is horrifying. It means that kids and families are really poor, back to point #1, but also it doesn't pay well. It's a slow system to change, and we need to do more to make changes in Medicaid for our kids and families. 60% of children 0 to 3 are covered by Medicaid. 50% of our pregnancies and births are covered by Medicaid in this region. 60% of hospitalizations at the Children's Hospital are covered by Medicaid. Thank you, Jana. Okay. Now that I've depressed you all, there are still tremendous successes in this community, and I have great faith in the work that's done in our community that we could be different. So look at the first two presentations you just saw. I cannot tell you enough how impressive that is. Another thing that was really impressive that it really speaks to the pediatricians and the independent practices is immunizations and lead testing, as LJ has shared with you in the past, did not decrease from 2019 to 2020 during the pandemic in our region. How did you guys pull that off? I mean, everyone else in the world is talking about 40% decreased immunization rates in Atlanta and 50% immunization decrease rates in San Francisco, you know, amazing. And I'm going to talk about two of the other successes: long-acting reversible contraception in our community, which many of you have been part of, and the developmental screening and support for 3-year-olds that's happening through the GROW initiative, community-based organization at the Children's Institute, partnering with many of our primary care intercity practices. Thanks, Jada. There's a reference there if you want to read more about those things. So long-acting reversible contraception, many of you participated in that, right? How many of, can you either show on your screen, if you can share, hold your hand up, or by video, how many of you are participating in placing LARC in your practices? I hope all the OBs are. I bet they all are. Carolyn is. Yeah, so this is a tremendous success for our community, okay? Between 2013, the third bullet there, between 2013 and from 4% to 24% of sexually active female high school students, teen pregnancy fell from 16% to 4.1%. But wait, it gets better. The trend has continued because the LARC data that we have is not contemporary, but the teen pregnancy data that we have is fairly contemporary, up to 2019. The trend has continued in our region. The rate of teen pregnancy now is 1.3%. From 2013 to 2019, our teen pregnancy rate dropped from 16% to 1.3%, better than New York State, better than any region in New York State, and better than the US rates. You should all clap for yourselves. I'm not kidding. Stephanie, clap for yourself. I mean, this is just unbelievable, right? Think about the difference for our kids and families, for adolescents who don't want to be pregnant, to have this kind of care. Tremendous. Okay, one more slide. Then we get to look at the future. This is the GROW initiative. Some of you are probably familiar with this, and your practices have worked with it. It's worked closely with the practices at Jordan and Golisano Children's Practice. And it's also worked in many community-based organizations, and it communicates with primary care. So it's an extension of primary care, not an exception to primary care. But this is an initiative started by the Children's Institute to focus on kids who have Medicaid. Overall, the numbers of kids served are 90% who are on Medicaid. And over the course of the last 7 years, they've screened over 7,759 children, because that slide is a few days old. And they've screened them comprehensively with the best evidence-based tools. And you know what? It's really important that they screen them because guess what? Close to half needed a referral for an additional service. Yeah, their vision or their hearing or their speech or their teeth or their developmental status or their emotional health status was something that needed additional attention. Unbelievable. And it's really a testament to our community that this has been lifted. And there are lots of practices, and there are probably some people on here I should thank if I scroll down the screen who have been really involved with this from their practices. And I have to say, again, thanks to AHP for making this work possible in conjunction with primary care. Okay, next slide. So what's the future? Well, I think the future is up to us. Alan Kay, I don't know how many of you had one of these. I had this, I wrote my thesis, my master's thesis on this type of computer. But Alan Kay was the inventor of the computer language that formed the basis for Macintosh and Windows, for Apple and Windows. And this is one of his sayings: the best way to predict the future is to invent it. We could invent a different future here for kids and for ourselves. Look at those successes. And that's what I want to think with you a little bit about going forward. Okay, next slide. So lessons learned. Katie did such a good job of talking about the lessons learned from her work in breastfeeding and lactation. But you know, I have some lessons learned too, and part of them I've learned from Daryl and Holly and LJ. First of all, one thing is we need money. Resources are required. Children are 34% of the New York State's Medicaid population, and they get only 9% of the funding. Come on. Medicaid is 37% of the New York State budget this year and every year. Medicaid is a $77 billion line item in New York State, and 50% of kids are on Medicaid. We have to do this work together. You know, this is a hard one. We have to partner, and the partnering needs to include families and youth and kids and educators and community-based organizations and every one of our health professions, right? Look at the beautiful work that the GOG, the Women's Health Practice, did together in that first presentation. And look at the way they presented, right? You know, we have to forget about hierarchy, and we have to start thinking and forget about territory, and that's hard. And think about kids, and think about the value of the work that we do, and make sure that the value of the work we do is being acknowledged. We need to start with what works and what's been shown to be effective, right? In both of those presentations, Women's Health Practice started off by talking about the fact that they started with 3 evidence-based approaches. It takes time. In the work that's happening in our community, I think it's 4 to 5 years minimum, maybe 3 years if you're really, really good, for new models to take root. And we have to start thinking about taking the things that are really working well to capacity. So those last 2 presentations deserve to be replicated, and that's a ton of work. And we can't clone Katie, but we can help her. And you know, some of the comments, Carolyn Cleary, Doug Bennett, were about how do we help each other to do more of this kind of work together? How do we bring it to pediatrics? And the last thing I just really want to say is courage is required, and being a little scared is where I am most days. You know, like, have we, it's scary for kids and families, and I know it's hard to do things in the face of that, and yet we have to. Okay, last slide or two. Oh, so the opportunity that we're going to have together is to advocate regarding the New York State Medicaid waiver. And this is a 5-year plan for innovation for New York State. They're applying to the federal government for it. It is for $13.52, yes, billion. And guess how many dollars are required for kids in that $13.52 billion that is currently being considered in Washington? $0. $0 are dedicated to kids. Not 1 penny is required to be spent on kids or maternal health. So many of you have advocated already, and I am so grateful. There are people on the call like Rich Bloom and Carolyn Cleary and Eva Pressman and Daryl Sharp and Jen Bruno, who I've seen all send comments into CMS. We're going to send comments into CMS in 1 minute, if you haven't done it already. Continue to partner with AHP and the other organizations that allow for collaboration, planning, and acting. You know what would be really great, I just have to say, is if we had 1 ACO for kids across the community, and if we stopped talking about territory and had an ACO for kids and you all participated in it, and we could do truly work on a population health level. We're capable of that. Most communities aren't. All right. And then join the work of local advocacy organizations. So on those slides, and you'll get this in your packet, there are opportunities to sign up for the Children's Agenda listserv, opportunities to sign up for the Schuyler Center listserv. These are the major advocacy organizations in our region and in our state that are really focused on women and children's health. They do a superb job. They need your help. We're meeting with some pediatricians later this week. Carolyn Cleary is one of them, to talk about how to help connect pediatricians and the Children's Agenda and Schuyler Center more. Okay, ready for the advocacy part? Okay, so here are the recommendations. I'm not going to read through these all because you're going to read them in a minute. If we can have you click on a link, you're going to be able to read these, and you're going to be able to enter a comment into CMS. And LJ, I'm sorry, I'm running 3 minutes late. Enter a comment into CMS. Jana, I'm sorry, I'm running 3 minutes late.
Jeff, you're fine. You're fine.
So
Just take your time. You're good.
These are the comments that we came up with from the Children's Agenda. So rather than $0, how about 2.7 billion for kids and women in the state? How about requiring that? And that's based on the population of kids and women in the state, and how many of them are on Medicaid, 39.5%. We need help from CMS to make sure that they cover screening and development. We need help from CMS to make sure that they are focused on mental health. It's a crisis, and right now New York State is dedicating 0 of their Medicaid dollars in this new waiver to the mental health crisis for kids and families that you're all worrying about every day and keeping you up all day and all night, and for women who are depressed and anxious, right? And then lastly, we want continuous coverage. This is an idea that came right from this group in Rochester at an AHP meeting. Someone said, I don't remember who, LJ, you might remember, someone said, why can't kids be covered through their first 6 years of life? They don't go off of Medicaid, they're all still really poor. And this idea is actually being entertained now. So you can pick any one of those recommendations and type to CMS. Can we share in the chat the link for CMS? Has someone already done that? Oh, that doesn't look good.
Oh, I'm gonna try
Let's
it
click
again.
on it and see what happens.
Oh, I don't know. Let's see. Nothing.
Yeah, you got the site.
Did it work?
Yeah, it works.
Good.
Okay, so if you click on the link that is in the chat, and if you haven't done this already, and I don't know if you can vote early and often, you might be able to vote twice. I wouldn't object to that. If you haven't done it, please click on the link and put in a comment to CMS that says, we need dedicated funding to women and children's health. Please, please, please. And you can add any of those other recommendations, and then make sure you add a sentence that's yours, something that you feel from the heart, and sign your name. And that will go through to CMS. And they are making a decision about what to do with New York State. And this is a really important and our only opportunity for feedback. So I just want to ask people to do that, maybe as we entertain a couple of questions for Katie and for me in the last 4 minutes.
Jeff, thank you. So those of you who haven't already had a chance to advocate, feel free. Click on that link. Just remember what Jeff said. You need to sign your name, please. Sign your name to it.
Yeah, you have to sign your name. And David, you're right. It takes less than 5 minutes. It really takes less than 5 minutes, but you have to do it. You have to type, it's tough. They make you enter it so that they're not getting, they're not getting blasted by spam or a virus. So you got to enter your name and you got to enter a comment. So I'm gonna ask for one thing before any questions. I'm just gonna ask for people to unmute themselves for a moment and please give everyone a good round of applause, and then we'll come back for questions. Unmute yourselves, please. This was really nice. Thank you to the presenters. And that was bad Leo Brown.
It sure is. It sure is. He loved the presentations as well.
That was awesome. All right, everyone. So I'll watch the chat. Feel free to unmute yourselves, ask questions, do your advocacy moment, and we will hang on in this room for a few extra minutes past 7 o'clock if there are questions that folks have. This is the beginning. Doug Bennett did his advocacy. Rich Bloom did his advocacy. Jeff's I saw him. I check the site every hour. So Dave Topa mentions, don't be afraid to talk to teachers and friends and families about this. This is true, but this is your final moment. So I think Jeff said, we actually were afraid that the site was going to be closed by the time the grand rounds happened. but it's still open. So maybe it's open till midnight tonight, but this is key. We were talking about this, that kind of investment in kids and families, that would change the world. That would be crazy good. And then we could have the money to do the good work, but it would be every kid in New York State, right? Okay, so what's in the chat there? Send the link to all your partners and associates. Thanks, Doug. Many of you have gotten it through, it's been shared everywhere. Every place I go, I keep, somebody says, have you seen this yet? And I think, I know exactly where it came from. Yes, I have. Are there any other questions? You guys are all so busy typing. I love you all. It's good. So I'm going to talk at you for a second. Kathy Goodfellow says, thank you, great update. Hard to unmute as I sit on Denver Airport. Yeah, you don't want to call attention to yourself there. Thank you, Kathy, for the comment. We appreciate that. Jana has just put up a slide. Jeff talked about the LARC initiative, and I just want to remind you all, for those who may not have heard us announce this, we are re-upping the LARC initiative in a big way, because there's never been a time where it's been more important for teens and adults to understand evidence-based contraception, and for us to be able to do a really good job talking about it with them. So these LARC training sessions are not for the placement of LARC. These are all about knowing what the most up-to-date information is around reproductive health, and to learn ways to increase access, and really fine-tune your evidence-based and patient-centered counseling techniques. So Jeff, you're putting funny things in the chat. I see this. So Dr. Rachel Phelps, who many of you know is an expert in this space and is a fantastic presenter and educator, is going to join us for the exact same talk 2 times, Thursday, November 17th, and then again, Wednesday, December 7th. These are Zoom sessions. You don't have to go anywhere. You can sit and eat your dinner while you listen. They're 1 hour long with 15 minutes for questions. And that's a really important priority for us. We're going to be emphasizing that in our provider engagement reports, and acknowledging your participation. This is for all of the providers in your practice, your nurse practitioners, your PAs, your physicians. If you want your nursing staff to join, please do. These are going to be really important. So Jeff made a comment back to Kathy, booing for the Broncos. That was really good. And I think the chat room is actually pretty quiet. So now I'm going to shut up. Did I miss anything in the chat, Jana? No. It is 7:01. We're going to leave the room open in case somebody finishes hitting their advocacy submission and wants to ask Jeff or Katie a question. Katie, if you can hang with us for just a couple more minutes. But I would like to excuse all of you who are done with that and would like to leave the Zoom room and go back to your evening. We're grateful you joined us. This is the start of many. Oh, yes, go ahead.
I just wanted to make sure that people saw the survey link. I am dropping it into the chat right now if anyone wants to grab it before they duck out of the room.
Oh, thank you, Gina.
So please, 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 please fill out the chat, fill out the survey at some point. You'll also get this in the follow-up meeting as well if you don't catch it here. The QR code will also link to it. So if you want to grab it quickly on your phone, we want to make sure this is accessible for you guys. So with that,
this is super quick. This is a survey that will take you less than 2 minutes to complete.
Less than 2 minutes.
It's a check, but it does help us make sure we're doing the right kind of programming.
Yes.
That matters. And if you have other suggestions for us for the next round of these kind of talks, please let us know.
Now I will stop sharing my screen and leave the room open for questions.
Thank you so much, everybody.
Daryl, thank you.
I'll hang around until we are empty, just in case.